I'm Rob Rapaport. I'm a professor of pediatrics at Icahn School of Medicine at Mount Sinai. I'm the former division director of this department, and one of my main interests is about growth, and I'm the director of the Comprehensive Growth Center. I've been at this for a number of years and with a major focus on growth. So what we do is we see patients for growth disorders and try to diagnose and treat them as appropriate. Growth hormone deficiency means when we do that 3-hour growth hormone test, it shows an inadequate growth hormone production, and the IGF-1 can be low. IGF-1 deficiency, however, and one could call it that, could be due to growth hormone deficiency, but it could be due to having excess growth hormone and a problem with the growth hormone receptor. There's a condition called Laron syndrome, which specifically exemplifies that. And that's a very rare condition, but very difficult to both diagnose and treat. If those children do not respond to treatment with growth hormone, they may respond to treatment with IGF-1. That's a rare condition. Similarly, gene deletions are quite rare. And in fact, we're just about to report a child who was diagnosed with severe growth hormone deficiency. She was treated with the growth hormone. And then when treatment was stopped, we rechecked her IGF-1 level. It was very low. We retested her ability to make growth hormone, and it was quite low. That person had a growth hormone defect in the growth hormone gene. Some of those patients do not respond at all, but some respond very well. And that's a very, very rare condition indeed. The important thing is monitoring. Measure the children appropriately, plot them on appropriate growth charts. And if a child starts out at the 50th percentile, and then a year or two later is down to the 10th percentile, that's something to be looked into. The first thing you'd want to make sure is that they're well nourished. Monitor their body mass index. See if that's normal. If there's a problem with nutrition, then that needs to be addressed. We measure indicators of inflammation like CRP and sedimentation rate, because occasionally chronic illnesses can present with growth failure. Then once that's done and we make sure there aren't any systemic illnesses, no kidney disease, liver disease, etc., then we measure IGF-1, IGF binding protein, along with thyroid function tests. And then we proceed with monitoring them. And if they don't grow properly, then we go on to the next steps. Pediatricians and primary care physicians are the main source of referral for us. They're the ones who see the children on a regular basis. It's very important that all the children be measured. And by that, I mean be measured properly, not with shoes. That their heights and weights be plotted on appropriate growth charts. And then if there is a deviation from norm, then they should pay attention to that and initiate investigations, and when appropriate, refer them. But we emphasize this to parents as well as to primary care physicians. They need to monitor the children's growth, and it doesn't matter at what age. They shouldn't wait till a certain age to consider referring them. As soon as you see a major deviation from the norm, they should act on it. Let me mention another thing, is a note to pediatricians and to primary healthcare provider. Number one is that you want to look at growth in all the children, which means boys, but also girls. Girls are, by definition, underdiagnosed. Growth failure is under-recognized in girls. Similarly, children for minority and underprivileged populations tend to be underrepresented in any form of growth hormone treatment. So it's important to pay attention to that. The challenge is to make sure that the children are paid attention to and they monitor their growth appropriately. Measuring children is not as simple as it sounds. Measuring a crying infant, you need to have patience and the skill to measure that. Older children, it's important to measure them appropriately and to plot their growth appropriately. And those would be the primary care challenges. The common conditions are variations of normal, like familial short stature or constitutional growth delay. However, rare conditions of inability to produce sufficient growth hormone, or even more rare, that the growth hormone does not act properly, does not attach to its receptor properly, does not form post-receptor products properly, those are extremely rare. And those conditions require specialized assays, and very frequently we involve the geneticist to be involved with us. And then what the usual thing is, if the children do respond to treatment, then we follow them until they reach adult height, which is when their bones fully mature. And then we retest them to see if whatever growth deficiency we had persists. And it persists in a very small percentage of them, but in those that does persist, they need treatment as young adults and adults. Any child in whom we diagnose growth hormone deficiency, we also do imaging of the pituitary gland, which is the source of growth hormone. In the vast majority, it's normal. In some, it's just small. In some, there are structural defects. And very rarely, tumors can present like that. A significant but rare tumor is craniopharyngioma, which we know presents with growth failure as one of its initial findings. And that's important to diagnose and treat appropriately. It's very important that these be diagnosed as early as possible. Occasionally, we see patients who said, oh, my pediatrician said, oh, we don't do anything until they're 10, 12, whatever years of age. And that's wrong. We need to do this as soon as a suspicion is there. So if they're 2 or 3, and many studies have shown that even with treatment, if treatment starts early, they achieve a better end result. Important also to monitor and to be aware of the children's birth weight and birth length. There's a condition called small for gestational age, and we published not long ago an international consensus on that. And that is that the birth weight and birth length are less than 2 standard deviations below norm at the time when they're born. 90% of them will catch up within the first year. But if they haven't caught up and they remain short and short for the family, then treatment is an option for them. And there are many data that show that earlier treatment, earlier recognition leads to better success as adults. The management starts when we make the diagnosis. We've excluded any other conditions that could affect growth, like celiac disease. If they are diagnosed with growth hormone deficiency, then we treat them with human growth hormone, which has been an injection, continues to be an injection, usually daily, but for the last 3 or 4 years, there's a weekly preparation that's available. We monitor those children roughly every 3 to 6 months. We monitor the level of IGF-1 that's achieved, make sure there are no side effects. And any treatment can have potential side effects, although growth hormone treatment is entirely safe for the vast majority of patients. We monitor them until growth ceases when the bones fuse. And we monitor X-ray bone ages roughly about once a year. And then you want to guide people away from false advertising, like growth hormone being used for enhancing youth and stopping aging. And there's a whole industry around that. There's also many products, if you look at the internet, that supposedly make you grow better, like gummies, like patches and all that, none of whom have any scientific basis on which that they should be used. So there have been huge advances in the field, but the first one is starting from the basic. If a child isn't growing well, if he or she is falling behind in height, then one needs to evaluate them. And the first thing we do is to make sure there aren't any nonendocrine causes that could interfere with growth. Globally, the greatest cause of poor growth is malnutrition. We don't see all that much in the United States. But for example, a condition that is overlooked a lot of the times is celiac disease. Sometimes parents will tell me, oh, we tested that 4 years ago and it was normal. But no, we tested again. And every year we diagnosed at least a handful of children who have celiac disease. Once all those conditions are excluded, then we focus in on the hypothalamic pituitary growth axis. And the way we do that is we measure IGF-1 and IGF binding protein. If those are low, then and the children aren't growing well and they're short, then we do a 3-hour test to actually measure the production of growth hormone. Each of these tests by itself is not all that important, but together they paint a significant picture that then leads to a diagnosis of perhaps growth hormone deficiency.